continue with the next lecture. Professor Anna Marting is going to give us a talk about the patients that suffer from COPD. And we know it happens quite often in our patients. And Professor Anna Marting is well known to most of us about her brilliant work in Stockholm trials and also in brilliant work in the ESP, in the program committee and the scientific committee. Please.
Thank you very much for that kind introduction, and again thank you for the invitation to come here. It's a fantastic meeting, really. And also I'd like to thank you for this a bit challenging lecture, I think, especially for a surgeon, but it has been great fun to look into the literature and also realizing that not has been done that much regarding colorectal cancer surgery, and I guess that was the reason for giving it to me. I will talk a little bit about the chronic obstructive pulmonary disease itself, and then about the risk those patients have in colorectal surgery and colorectal cancer surgery specifically, and also a bit of what we can do to be aware of that and perhaps lower the risk for those patients. Chronic obstructive pulmonary disease is a very common disease. If you look at patients over 45 years, the prevalence is about up to 15%, and it decreases with age. So in a smoker of age 75, almost 50% of the patients do have COPD, and it's probably even more than that, I would say, because this is a diagnosis that is commonly missed. It's an underdiagnosis. So you only get symptoms when your pulmonary function is really reduced more than 50%. There are some gender differences also. Women seems to be more prone to get COPD if they are smokers compared to men. And the diagnosis is more common in cancer patients as they are sharing the same etiology, namely smoking, because smoking is the predominant risk factor for getting COPD, as you all know. But there are also other risk groups, as those having an occupational exposure to respiratory irritants. And there are some very rare hereditary forms like the alpha-1 antitrypsin deficiency, for example, but also if you've had severe lung infections in childhood or bronchial hyperactivity, you're at risk for getting the COPD. The diagnosis you can get by spirometry, and that is the basis for the diagnosis. Symptoms we all are aware of is respiratory distress, wheezing, and a barrel-shaped chest. Those patients, when they have a severe COPD, they also have hypoxia, and they can have, in really severe cases, carbon dioxide retention. And as a result of the hypoxia, they also have a polycythemia, and that is also important to take into consideration during surgery and after surgery. What is also important with those patients is to notice that the comorbidity is quite severe. About 50% of them have severe cardiovascular disease as well, but also other comorbidity is quite common, as asthma, anxiety, depression, also other cancer forms actually, peptic ulcer, osteoporosis, and also the metabolic syndrome with a high rate of diabetes in that group. So what are the risks? Most of the studies that have been performed on COPD patients are performed on all kinds of surgery. But overall, of course, there are some anesthesiology challenges that you have to come into consideration. But also, of course, both pre, per, and postoperative the comorbidity, and especially then the high rate of heart failures. A large majority of the patients with COPD are on corticosteroids, and that also needs to be taken in consideration during surgery, of course, and anesthesiology and during anesthesia and the postoperative period. And also you have to, I will come back to that, take that into consideration when you use, perhaps perform anastomosis, etc. And also, as I said, there was an relation to metabolic syndrome, but also to malnutrition. Actually, in the very severe cases, those patients could have a really low BMI and a very bad nutrition status. Other risk post-operatively is, of course, the pulmonary infections and a high risk of respiratory failure. They do get, in a high degree, cardiovascular events. They have substantial healing problems and also a higher rate of anastomotic leakages compared to non-COPD patients. They also, as they have often very high levels of hemoglobin, they have a higher risk of thromboembolic events. And in addition, the cardiovascular comorbidity, of course. And they have overall in surgery a higher risk of increased ICU admissions and also more than doubled risk of postoperative mortality compared to a non-COPD patients. I said that we're very scarce evidence in the literature regarding colorectal surgery and COPD. However, there are two quite recent publications that have looked into that. This one Danish population-based study studying the impact of chronic obstructive pulmonary disease on intensive care unit admission and 30-day mortality. A large number of patients, and the rate is national-wide population-based, and the rate of COPD in that cohort was 8%. There's a very recent publication from Spain that, with 22 hospitals involved and a little bit less number of patients, but still almost 3,000 patients, and with a higher rate of COPD. So I will come back to those two. And they were all only colorectal cancer surgery patients, both of them. Regarding the Danish study, they showed in this population-based trial that patients with COPD had a much higher rate of admissions to ICU compared to non-COPD patients. They had a slightly higher rate of reoperation, and they had an almost threefold increase in postoperative mortality compared to non-COPD patients. Interesting also was that there was a higher risk in patients with colon cancer compared to rectal cancer with COPD. In the Spanish trial, they also studied postoperative complication, and that was not in the Danish study. And they showed that patients with COPD going through colorectal cancer surgery had a much higher risk of postoperative complications compared to non-COPD patients. They also showed a much higher rate of admissions to ICU in those patients, and also a higher rate, almost fivefold higher rate of postoperative mortality in the COPD patients compared to the non-COPD patients. In the Spanish paper and also in the other papers of other surgical procedures, you can see that the surgical complications are about an increase of about twofold in COPD patients, and that goes for, and the most common is bone rupture and infection, also actually evisceration, bleeding, anastomotic leakage, and that's resulting also then in longer length of stay, of course. And the reason for this is most likely multifactorial. Is, of course, it could be the malnutrition, that could be a risk factor for all those things, but also the low saturation in those patients, the corticosteroids that they are on, and some on really high doses, but also actually the coughing afterwards could be a risk factor for all those postoperative complications. What about then minimal invasive surgery and laparoscopy? Could that reduce the risk? Well, in COPD patients, these results are conflicting. What you can say from surgery, you have to take two things into consideration. There is a higher risk for the anesthesiologist during operation in the very severe COPD patients because of the high pressure in the abdomen. On the other hand, it might be, but on the other hand, you have less scarring, and it's perhaps an easier mobilization in laparoscopic operated patients, and that makes it also easier for them to do pulmonary exercise afterwards. So for example, in the Danish study, there was a favoring of open surgery. However, and in other studies, there has been equal results, some favor still open surgery. What you should remember is they are some flawed because historically the majority of the patients with COPD has been operated upon openly. However, there is a very recent publication from 2018, this is American material, comparing only COPD patients, about 4,300 patients. About half of them had open surgery and half of them had laparoscopic surgery. And in this study, of course, it could be a selection, it was not randomized. There was a favor in front of laparoscopic surgery in those patients with a reduced number of postoperative complications overall in the laparoscopic procedure compared to open surgery. So what can we do about it then? Well, we can do a lot, I would say. We have to have awareness of this disease and take action accordingly. We should refer the patient with COPD for spirometry and in some cases also radiology of the chest to exclude, for example, ongoing exacerbations and infections. And you should call a friend, you should call your pulmonary expert actually, so they can help you to optimize the patients in front of surgery. And you can also consider actually rehabilitation in those patients with training to stop smoking and nutrition. And most of them have already stopped smoking, but if they haven't, they should. And I will show you why. Regarding rehabilitation, there are well-known beneficial effect in COPD overall, that if you train your inspiratory muscles, you get better. However, there are very few studies that have studied this rehabilitation in front of surgery in those patients. So we have to take the results from other surgical procedures to see if there is any use really. And the majority of those are done on AAAs or esophagectomy. And you can see here by 1 to 4 weeks training of your inspiratory muscles, you can improve your function and reduce the pulmonary complication. It's actually 2 RCTs showing this. Regarding physical exercise overall, it's the same situation. We have a well-known effect in COPD patients overall, but very few have studied this in front of surgery. However, there are, for other surgical procedures, 6 RCTs that has been studied this, 2 to 6 weeks of training, home-based and supervised sessions, 1 to 3 weeks, and 3 of them showed reduced postoperative complications after training. The COPD are risk patients, and there are actually one study that I have found very recently that has studied rehabilitation in risk patients, and this was a study concerning 125 patients with a low Duke activity score that had 6 weeks of exercise, and you can discuss if you have that time, but they could show that even in risk patients you have an effect or even a more effect on the postoperative complications, so there might be something in there. So last, smoking. For COPD patients overall, we know that it's good for them to stop smoking, and however, there has not been a randomized controlled trial or anything in those specific studies, but there has been in colorectal surgery, and it's debated how long you have to have a stop before, and in that study it showed that 2 weeks is not enough. Studies on gastrectomy has shown a little bit varying results. If you take all the literature into consideration, you probably need to stop smoking for more than 4 weeks to have an effect, actually. Then during surgery, what can you do? Well, it has been discussed if it's better to have only an epidural anesthesia compared to a general anesthesia, and that was a hot topic in the 60s and 70s. I think most anesthesiologists today like to have control and prefer general anesthesia, but in combination with epidural to be able to reduce the height of their anesthesia. And as I said, lap is that better than open. There are some recent studies that indicates that it might still be better with laparoscopic procedures in those patients. But as surgeons, we have to be aware of the risk of wound healing complications, bleedings, and especially also think twice before you put an anastomosis in the abdomen with patients on corticosteroids and healing the defects like COPDs. So postoperatively, finally, be aware of the risk of complications and the associated comorbidity, and have a close surveillance on those patients, and have a low threshold for going further on investigation for anastomotic leakage, etc., etc. Postoperative analgesia is very important so they can breathe and they can have their exercise. So an epidural catheter in those patients is necessary, is very good. Thromboprophylaxis we always give, but this is very important in those patients. And most of all, you have to mobilize them early and also get the respiratory physiotherapy to them, and also, of course, bronchodilator therapy to be able to mobilize their lungs. So, in conclusion, COPD is common in our patients, especially in the cancer patients, and they have a high risk of complications overall, or for ICU admissions, for reoperations, and almost 5 times higher risk of postoperative mortalities in some studies. So be aware and take action. Optimize the treatment of the patients in front of surgery. Consider rehabilitation. Plan surgery accordingly, and have an intense postoperative surveillance in those patients. And think especially of the respiratory physiotherapy and early mobilization. Thank you.
Thank you, Professor Marting. It was a topic that seems to be easy, but it troubles us a lot, and gave us some answers at least. Is there any question from the audience about it? Professor Xinos?
I'm very glad I had the idea to ask you to speak on this topic. It was excellent, as if you were in my mind, what I wanted to hear. And what bothers, and actually, after what we've heard and counts us down somehow, is that at home a lot of people smoke. It's not only 50% above the age of 75, it's much higher. And none of them, they agree to stop everything apart from stop smoking. And in our hands, and possibly you may blame our hands, almost all of these patients who have low rectal anastomosis and deny not to have them, they can accept the danger, they almost all leak to some extent. And this is the problem. We try to convince them that you may need, it's better to do a stoma or to do. Alternatively, now we're moving towards all this, just Dr. Romano said yesterday that we try to apply now the pull-through technique for the low rejections. And this is a terrible problem because although you inform the patient, they are difficult to accept. Even the full rehabilitation program, they don't succeed to comply with that. We do, of course, all the fast-track work after that, but still it's not enough for them.
No. It only shows what kind of strong drug nicotine is, really. So you have to threaten them perhaps with mortality. That could be more effective because they really have a high mortality risk. But no, it's a problem, and you really have to have that in mind.
Are you sure that even if you give up smoking, it will improve your leak rate? Because in breast cancer, one of the rationales for neoadjuvant chemotherapy is that you can persuade some patients to give up smoking. You can get their diabetic control better, prehabilitation in breast cancer, but they still have awful results if they, for patients who have smoked, even though they do these things, they have a much worse cosmetic results. So I'm not sure that even if you got them to give up for 4 weeks, you'd improve the leak.
No, I don't say that. More or less, it's pointless to ask a patient who's been smoking for 40, 50 years to stop for 4 weeks. But this might help only his lungs, only. Yeah. Not to improve the immune response or anything else. These are bad patients.
You probably need longer time without smoking.
Yeah. Okay, thank you.
Yeah.